Good morning. I'm hoping you're able to hear me now.
Yes,
Wonderful. Okay. Apparently one link works and one doesn't, but should we go ahead and go get started this morning?
yes, that'd be great. Thank you.
Wonderful. Well, good morning, everyone. Thank you so much for joining us for VCU Cardiology Grand Rounds. It's my pleasure to introduce Dr. Mayer today. Dr. Stephanie Mayer, MD, is an associate professor of medicine in the Division of Endocrinology and Metabolism at the Central Virginia VA Healthcare System, as well as VCU. She trained at Brown for her internal medicine residency and then went on to Duke, where she completed her fellowship in endocrinology. She also completed a master's in health science research at Duke DCRI. She's one of four national champions for the joint VA and DoD clinical practice guideline for the management of adult overweight and obesity for the 2020 published update and now is part of the 2026 update as well. She's the Richmond, Virginia champion for the MOVE weight loss program. And her current clinical research focuses on predictors and metabolic outcomes of weight in veterans engaged in the VA MOVE program. Her passion includes teaching endocrinology to her students, trainees, colleagues, as well as her patients. So with that, it is a pleasure to introduce you. Dr. Mayer, thank you again for joining us today.
Thank you so much for that kind introduction. So let me just get my slides up right here. Perfect. So good morning, everyone. It's a pleasure to be here with you to present this important and very rapidly evolving pharmacologic landscape and the intersection of endocrinology and nearly every other organ system, including, of course, the cardiovascular system, with the underlying linchpin culprit, which I'm trying to encourage folks to think about, being obesity. And our objectives today, my goal is to review this fairly newer class of agents, NUSHs, so nutrient stimulated hormonal therapies that include glucagon-like peptide 1 receptor agonists, as well as dual therapies. Currently, the only one on the market right now is the chimeric dual agonist GLP-1 and GIP, glucose-dependent insulinotropic polypeptide, as well as triple therapy, GLP-1, GIP, and glucagon receptor agonist is the furthest one, retatrutide, and there are many others in development that are not yet commercially available, but many in the pipeline, which is exciting. We're going to look at the pros and the cons, as well as some of the unanswered questions about this class as a whole. And then I also want to make sure to empower you to look at medication lists with awareness that medications affect weight. I didn't start teaching medical students this fact until 2019. So a lot of us in medicine are not aware that there are going to be some choices for folks who are struggling with weight that are going to promote weight loss versus others that are going to cause further weight gain that may not be in their overall whole health best interest. So let's start today with a case to introduce some of our major points. So Mr. H is an 80-year-old man. He presented to the VA weight clinic, the MOVE program, for help in managing his obesity because he wants to qualify for hip surgery for osteoarthritis. And he was told that at his current BMI of 44 kilograms per meter squared, he doesn't qualify. He does have additional medical history, as you see here, of diabetes that is complicated by both microvascular and macrovascular disease. He's had a stroke that has left him with some left arm residual weakness. He does have the presence of a retinal cholesterol crystal emboli, a Hohenhurst plaque, which suggests that he has lipid metabolism concerns on fundoscopy, and also suggests atherosclerotic kidney disease as well. He does endorse emotional eating when he's bored. He says, when I'm busy, I think about it being food less. He recently lost his job at 80 years old because of mobility issues, and saying, with a lot of sadness, I just couldn't keep up with them youngsters, and that still hurts. And he had been at this same job since 1964. And let's look at his labs here. So he clearly has uncontrolled diabetes with an A1C of 9.4%, which most endocrinologists would at least try to get the A1C to 8% or less. That's where there's a cut point in terms of higher risk for glucosuria, urinary tract infections, volume depletion, infection, and other complications over time. It's complicated by microalbuminuria. So he has CKD, which we're going to talk about in a little bit, why that might be important to keep in mind. And a lipid panel that, in my opinion, certainly leaves something to be desired in the history of a prior stroke. I would probably want an ApoB level as well. And his blood pressure perhaps could use some improvement as well. On exam, he's older. To me, he appears frail. I am seeing him by video, but he has to use his arms to get out of his chair, to go ask his wife to be part of the visit, and he has a shuffling gait. And so let's turn our attention here to our topic of incretins. So it was discovered that the route of glucose administration actually has a large effect on the amount of insulin response. So when you compare an IV dose of glucose administration versus oral, you get a significantly increased hepatic uptake that has been that was termed at the time the gut factor and later found to be incretins. So incretins are these gastrointestinal peptides. They're produced by the L and the K cell of the small intestine. The most common is the GLP-1 glucagon-like peptide that we're familiar with, and we're going to probably spend the bulk of our discussion today, as well as GIP, glucose-dependent insulinotropic polypeptide, and there are others as well. They are released in the setting of meal intake, so that's where the term nutrient-stimulated hormonal therapies comes from, and they do stimulate pancreatic insulin synthesis and secretion. There appears to be an impairment in GLP-1 response in the setting of type 2 diabetes, likely due to reduced postprandial secretion and other mechanisms. And in folks who live with obesity, which we're always going to use obesity as a noun and not an adjective for being patient-forward speech, it seems to not be as effective. And so the pro-glucagon gene is expressed in several tissues, including pancreatic islets and intestinal L cells. And this gets synthesized as the protein pro-glucagon. And I'm just showing you this to explain kind of where the word GLP-1, glucagon-like peptide 1, got its name, because it was initially very confusing to me. It has the opposite effect to glucagon, but that's simply because of how it was first discovered in its processing. So let's talk about these GLP-1 receptor analogs. So they are effective, and this is for reducing hemoglobin A1C by 1 to 2%. And animal models suggest that they do stimulate beta cell proliferation and differentiation, preventing diabetes. That's not been as easily teased out in human beings. But there's a little bit of data that suggests promoting beta cell regeneration and differentiation in rats, as we talked about. And we think that's by inhibiting apoptosis at the mRNA level and different kind of protein upregulation that occurs at a cellular level. Mechanistically, it works by enhancing glucose-dependent insulin secretion, but only glucose-dependent. So by itself, it's unlikely to cause hypoglycemia, which is another reason that it's favored, this class. It does slow gastric emptying, so that could be a reason that you may not be able to use this medication class if someone already struggles with gastroparesis, because that's going to further worsen that. It does reduce actually postprandial glucagon release, so less rise after food intake. And it does work centrally at appetite centers of the brain in the hypothalamus to reduce food intake. Side effects do include the majority, the most common side effect, I should say, are going to be gastrointestinal. So upwards of 40, 50 or more % of people on these agents are going to get some kind of nausea, either diarrhea. More people tend to get constipation, reflux, also things like headache, dizziness, hypertension, and tachycardia might be of import to your team especially. It is contraindicated in history of medullary thyroid cancer or MEN2, multiple endocrine neoplasia 2A or 2B. And that's because in rats, it does show hyperplasia of C cells of the thyroid gland. The problem is that rats have a different ratio of C cells in the thyroid, but currently listed as a black box for all of these agents. We've already talked about some of the precautions, gastroparesis, history of pancreatitis. That's also a little bit debated. In the LEADER trial, there were actually more cases of pancreatitis in the placebo arm than in the treatment arm. But if you have someone with a history of recurrent pancreatitis and you start them on one of these medications, a lot of people, in a court, I think that's going to be difficult to justify. So perhaps unless they've had gallstone induced pancreatitis and the gallbladder has been removed, most of us would probably hesitate in that case. We've got some examples here that are currently on the market, and typically subcutaneous injection daily or weekly, although there is an oral Rybelsus of oral semaglutide, but we'll talk in a minute where these are not all equal in terms of cardiovascular outcome trial results. So for weight management, it got approved in 2021, and it is quite effective for the semaglutide. We'll talk about since then, more effective agents actually are now on the market, including tirzepatide, the dual agent. So I think we've talked about most of this already. It can increase serum amylase, although we don't typically test for that either at baseline or unless someone is presenting with symptoms that suggest pancreatitis. So in this systematic review by Satter et al., they're looking at folks who have type 2 diabetes, and it's a systematic review of 8 cardiovascular outcome trials. And they're using this random effects model, and they're estimating the overall hazard ratio. And overall, they're suggesting a reduction in major adverse cardiovascular events from GLP-1 receptor agonists by 14%, hazard ratio of 0.86. With a confidence interval that does not cross 1. It actually had a reduced all-cause mortality by 12%, reduction in hospital admission for heart failure by 11%. We're going to talk about that a little bit more. Reduction in the composite kidney outcome by 21%. And we're going to talk about the FLOW trial in a little bit of semaglutide, with no increases in the severity of hypoglycemia, retinopathy, or pancreatic adverse events were the side effect profiles that they were looking at as well. We're going to look at, or one of my questions is actually to point to you, though, that they're not all equal. And 3 of the trials, specifically the oral semaglutide, did not meet its cardiovascular primary outcome. I apologize. Nor did the exenatide or the lixexenatide. But on the whole, it is considered as a class to be effective and has gotten FDA indications for as such. So now focusing squarely on heart failure with preserved EF. I know that some of my colleagues among you have this is your area of expertise. So you're probably very familiar with the STEP-HFpEF trial. This looked at 529 patients over 96 sites in different countries who had heart failure with preserved ejection fraction and a BMI of 30 or higher. And they were randomized to either once weekly semaglutide at the Wegovy weight loss dosing. Actually, diabetes was an exclusion criteria, so you could not have diabetes to participate in this trial. Had to have a A1C less than 6.5%, checked three months before enrollment, or placebo at 52 weeks. And the primary outcome was the Kansas City Cardiomyopathy Questionnaire clinical summary score. And they had a change of 16.6 points with semaglutide and 8.7 points with placebo. So the difference was 7.8 points. That was considered to be statistically significant and clinically significant in the author's conclusion, with a significant 13.3% body weight loss with the semaglutide and 2.6% loss in the placebo. I was actually intrigued by these secondary outcomes. So the improvement in the change in 6-minute walk distance, which I think matters to a lot of our patients and would matter to Mr. H. And as well as this interesting stratified win ratio, which I just thought very interesting, where they took the top performer from semaglutide and the top performer from the placebo and kind of put them head to head on different outcomes including, and to see which one was the winner. And overall, on the ones that they looked at, including the number of heart failure events and the time to first heart failure event, the stratified win ratio favored the semaglutide at 1.72. This is the Summit trial, and this is looking at tirzepatide. So this is the first time we're going to look at the dual agent agonist, GLP-1 agonist plus GIP, that's a chimeric combined dual receptor agonist compared to placebo, and had a significant improvement in the composite of death from cardiovascular causes or a worsening heart failure event with a hazard ratio of 0.62. So I really liked this European Society of Cardiology review article on the pathophysiology and the pharmacologic rationale for GLP-1 receptor agonist administration to patients who struggle both with obesity and heart failure with preserved EF. And specifically what they are concluding, which I think is a key take home, is that obesity is not simply a comorbidity, but it is the direct cause of heart failure with preserved EF, is their conclusion, and would be my perspective as well. The proposed mechanism that they're suggesting is that obesity leads to an inflammatory state of adipose tissue. And what happens is that due to hyperplasia of the adipocytes, they outstrip their vascular supply. And this is causing adverse effects on the structure and the function also of the vasculature and most visceral organs. The expansion of the visceral adipose tissue causes this oxidative stress, this release of the pro-inflammatory adipokines, of which there are actually hundreds. Activation then of the renin-angiotensin aldosterone system. The adipocytes then actually apoptose due to hypoxia, autophagy, which then promotes gut microbiota dysbiosis. And all of these mechanisms together lead to insulin resistance and predisposed to type 2 diabetes mellitus, dyslipidemia, increased vascular stiffness, hypertension, which then leads to coronary artery disease, and with further inflammation and death of myocytes, eventually to the heart failure with preserved EF. So this is taking a look from the American Diabetes Association perspective. And for a couple years now, every January they publish the standards of diabetes care. All endocrinologists have a second Christmas in January when these come out to see what's new and what the updates are. And specifically, they say that for folks, regardless of hemoglobin A1C, independent of A1C, folks who already have cardiovascular and kidney risk, either who have it present or at high risk, which they define that as an age greater than or equal to 55, with 2 or more of the additional risk factors that do include obesity, high blood pressure, smoking, dyslipidemia, or albuminuria. And they're defining ASCVD here as established, having had a myocardial infarction, a stroke, arterial revascularization, and sometimes include TIA, unstable angina, and amputation, symptomatic or asymptomatic coronary artery disease. You'll see that they suggest to start with either or a GLP-1 receptor agonist that has, and they do specify, proven cardiovascular benefit. We talked a moment before that there are some of the cardiovascular outcome trials that were not positive for all of the ones in this class, or an SGLT2 inhibitor with proven cardiovascular disease benefit. But several of the reviews are suggesting that because the mechanism of action of how they are being helpful is different, the majority of our patients, our shared patients, are likely going to require both. In this case, they say if A1C is above goal, my hope is that with more data, this will actually include more folks. Actually, I was surprised that the heart failure category here did not include GLP-1. I'm wondering if it's simply the timing of when those studies that we talked about recently got finally published and could be included. I'm hopeful that this will expand soon. And from a weight perspective specifically, we have tiers in terms of efficacy based on data for which agent is more effective. But to be completely frank and honest, as which all of us know, it's going to be dependent in my case on the formulary here at the VA, and in your case on what the insurance is going to cover, just to be completely honest. So taking a frank look at obesity, I want to make sure to review that obesity is absolutely a complex disease. And there's a very common misperception at all levels, from patients through leadership, that obesity is just a result of lack of willpower and individual failings to eat well and exercise. And I really love this quote by Dr. Ruth Peterson, that many factors contribute to obesity, and that it does include genetics, certain medications, which we're going to talk about that because that's something that we can impact directly, poor sleep, the gut microbiome, stress, access to affordable food, safe places to be active, and access to healthcare. So the trend is not going in the right direction. And every time I update my slides, it's a little bit more disappointing that we're currently now at 41.9% of adults living with obesity as of from 2017 to 2020 CDC data. It is quite morbid, and it is associated with increased risk of cardiovascular disease and cardiovascular disease mortality, quite costly, and it is negatively impacted by ethnicity, age, sex, and level of education. So I want to make sure that everyone here thinks about asking for permission. Weight can be a very sensitive topic for patients, but it may be critical as an underlying cause of their heart failure with preserved EF. So maybe taking an approach such as, I'm concerned about how your weight might be affecting your health, and in your case, you would say your heart health. Is this something that you feel comfortable discussing today? Now, if someone says no, then I would absolutely honor that and say, I absolutely understand. Let's focus on your priority today. I will, revisit this in future, and maybe giving them some time to think about it can be useful. I find this useful to me. When do you feel like you started to struggle with your weight? Was there something that occurred? Such as like for our gentleman, where there was an emotional struggle with weight, what was going on? Do folks struggle with weight in your family? There's a strong genetic component. And I always ask if anyone in their family has diabetes. I find this chart very helpful. I'm hopeful it will get updated soon, where it shows the amount of weight loss that is needed to affect an improvement on different aspects of healthcare. So with just a 2.5 to 5% weight loss, you'll get improvements in glycemic control, which can already be useful, and start to see some improvements in triglyceride. You need a little bit more to get an HDL increase. The AHI, apnea hypopnea index, can start to improve with 10 or plus weight loss, body weight loss, which we're going to see. Just very recently, tirzepatide got approved for an indication for obstructive sleep apnea treatment in the setting of obesity. And you'll notice here that specifically mortality, when you start to get to a 16% weight loss, and this is where we're at now with our medication therapy options, especially the dual and hopefully coming to the market, the triple agonist therapy. So it has been approved, semaglutide, has been approved in the setting of type 2 diabetes for the treatment of chronic kidney disease. This is largely due to the FLOW trial, 3,500 patients of semaglutide versus placebo in patients with type 2 diabetes, showing a reduced hazard ratio to the first major kidney disease event. And for you guys also, death from cardiovascular cause hazard ratio of 0.71. So let's talk in a little bit more detail about this combination tirzepatide, which is the current one, only one that's on the market, that is the GIP plus the GLP-1 receptor agonist. And there was a little bit of confusion initially, that if there is possible increased glucagon secretion, how is that going to be helpful? But it seems that in synergy, they do combine to improve both body weight and blood glucose. Some people argue that it's the GLP-1 component of this agent that is more effective at binding at the receptor. I think time will tell with more of these agents in the pipeline. And so this is very, very similar. It's just a little bit more effective for A1C reduction than the GLP-1 agonist alone. It does have in the package insert a higher risk for sinus tachycardia, however. So I wanted to point that out to this team. And it was approved in 2023 for chronic weight management with efficacy seen in patients, and I will note, without diabetes, of 23.6 kilograms, so 20% of body weight loss. So unfortunately, in all studies of all agents of all weight loss medications, folks who live with type 2 diabetes have less weight loss than the folks without type 2 diabetes attempting weight loss, unfortunately. I just mentioned this very briefly because it is in the package insert, and this is not actually in the package insert of most of the other niches, is this reduction in contraception efficacy. So if you have someone of pregnancy potential, they would need to be using a second method of birth control. The thought is that it's because of the reduction, the slowing of the gastric emptying. What's interesting, though, is then why would that not be seen in some of the other agents? Although when I saw the study that was done for semaglutide looking at effects on hormonal contraception, unfortunately, the study was done at the steady state, not at dose escalation, which is probably what we need to know. So I'm not sure that we have everything. So remember that weight loss increases fertility, so that if someone is not trying to get pregnant, you're going to want to mention that because that may not be in their best interest if that's not what they're seeking at this time. So little touch on that. Surmount OSA had folks who received the tirzepatide had a significant reduction in the apnea-hypopnea index, and it was somewhat commensurate with the body weight that was achieved. This did get recently FDA approved for that indication. We talked about rare to cause hypoglycemia. I don't think we have all the information, and we don't have the cardiovascular outcome trial data yet on the tirzepatide. That is planned to be published this year. As we all know on this chat, that cost is the largest issue currently on the table, typically. We're going to talk in a second, though, about additional concerns. Triple hormone therapy receptor agonist retatrutide. So that has the GLP-1, the GIP, and added glucagon receptor agonist together. So as a triple therapy, and now you're getting into average weight losses that are over 20%. So you're getting into the ranges that are seen with gastric sleeve. And this will be the first time that's going to be on the market. Now, let's talk about some risks. So in this post-hoc analysis of all the phase 2 and 3A randomized controlled trials of liraglutide from the Saxenda, so the scale studies for weight loss, the 3 milligram daily dosing. And unfortunately, this was made generic recently, and then they stopped making it because, why do that if they can't make as much money? So that's kind of unfortunate. But this agent did show an increased risk of active suicidal ideation. So that is something to keep in mind. Here at the VA, we worry about that a little bit more because our VA population is a little bit higher risk for suicide. So screening ahead of time, and if they have struggled with that, we get them to work with a mental health provider before we prescribe these agents for weight loss. And then what about the risk of thyroid cancer? So this is a group of scientists from France where they looked at everyone in the French medical healthcare system, which is 98+% of French people, to look at those who, and it was an interesting study though, because it was looking at patients who already had thyroid cancer and looking then subsequently of who had been exposed. I actually emailed these folks in French, I'm French myself, to see if they would help answer these questions because they didn't include people, they excluded people on insulin therapy, and they didn't give us an absolute risk, which I needed. So they did not respond, so I can't answer that for you guys, and it's not been published since then. So most of us feel like the risk is likely low, and likely the benefit probably outweighs that. Perhaps the hesitation would be in someone with a very strong family history of thyroid cancer and several first-degree relatives. Now, what about NION? So this is a relatively recent association of this rare kind of eye concern, non-arteritic anterior ischemic optic neuropathy, which my ophthalmology colleagues tell me is incredibly rare, but there did seem to be an association. I've not seen more published on the topic since then. Cost is a major problem here at RVA. Topiramate and bupropion from a population perspective would be doable. The tirzepatide Zepbound is 40 times more expensive than that. So that is why we have such tight restrictions. And how about when you stop these medications? So almost every study of every weight loss medication shows the same thing. When you stop a medication that is useful for weight loss, weight regain occurs. And it's not always to the exact same degree, but you're losing the majority of the weight loss that was achieved. And that's why the majority of us in obesity medicine definitely recognize that obesity is a chronic medical condition that should be treated in the same way that we treat other chronic long-term medical concerns that need ongoing support. And how about lean mass and body weight loss? So I dove into this just a little bit because it is concerning, but the problem remains that lean body mass is not actually a synonym of pure skeletal muscle mass. And the problem is that those always get kind of because it's an easier measure using mechanisms of measurement that are easier to perform, such as either bone density or body composition, but they're not actually the same. And the folks here, and also the second review article, which was looking at the different trials, they suggest that DEXA may not be the best mechanism to actually know what's happening to true fat-free muscle mass versus just lean mass, which also includes total body mass minus fat mass, which does include organs and can be affected by volume. They suggest that MRI is going to be the most effective means of diagnosing, of measuring that. But the problem is that MRI is very difficult to scale outside of research studies, and even within research studies, quite difficult to obtain due to cost. Here they suggested that there may be some glimmer of positive where they showed that perhaps there's still some adaptive benefit of the GLP-1s where there's some remodeling that's happening in terms of aerobic oxidation and mitochondrial biogenesis in the skeletal muscle. But they do conclude that in the end, we don't have the best means of, or outcome measures even, to feel confident that we're looking at muscle quality. And they suggest using a muscle volume Z-score and muscle fat infiltration, but that's not been widely published or done. So there's a lot of unanswered questions. This is a question that we're asking in our current updated guidelines, that once weight targets are met, what is the comparative effectiveness of continuing weight loss medication versus reducing or discontinuing medications on weight loss, weight maintenance, and other health outcomes? I certainly hope that next year I'll have at least what the data shows. The problem is that it may be early to answer the question, and we may end up having to say there's insufficient data and this is a need for further research. I do think, clinically, I feel like we're going to find that similarly to, you would never give someone a dose of Lasix that was more than what they needed, or a beta blocker that is more than what they needed, although you're going to see that I hope that you avoid beta blockade as much as possible because it increases weight. But the point is that I think that we are going to find that some folks need much smaller maintenance doses. Now, this is in stark contrast to the way the insurance companies have taken this on, which is incongruent with any other medication that we use clinically, suggesting that if the patient doesn't tolerate the highest dose, well, oh, too bad for them. We're just going to stop it. And I love this publication, which went through, especially in the pens that allow for titration, which is currently the Ozempic formulation, so not the weight loss options, which those are kind of pre-filled pens at a set dose. But I certainly, for folks who have struggled with GI concerns, used microdosing in those cases. I do want to make sure to mention, so Mr. H was on gabapentin, paroxetine, glipizide, metoprolol, and sertrazine. So this is the audience response section. Which of these prescribed medications is making it harder for him to lose weight and getting in the way of his weight loss efforts? Does anybody want to chime in here? And for the interest of time, we'll just kind of speed on through. But the point is that it is all of these agents, all of them. He's on 5 medications that is making him gain weight. And then we're wondering why he's having trouble managing his weight. And one thing that we're going to talk in more detail today is that beta blockers affect weight in a negative way. I really love this paper, the Gemini paper, where they randomized folks to looking at metoprolol versus carvedilol. It was a randomized controlled trial, double-blind, parallel. It is back from 2004, that is correct. And it was in patients with type 2 diabetes and high blood pressure. They discontinued all antihypertensives except for the ARB or the ACE, and then randomized them 2 to 3. Carvedilol 6.25 twice a day, or metoprolol tartrate 50 milligrams twice a day, and then dose increased as required. And the problem is that folks in both arms, and this was only a 5-month trial. We don't give beta blockers for 5 months. They both gained weight, and the folks in the highest quartile of weight gained the most weight from the metoprolol is the concern. And so the thought is that it's the difference between a vasodilating beta blocker versus a non-vasodilating, and having the vasodilation and allowing better basically oxygenation and movement of glucose and lipids is going to be helpful from the body perspective of insulin resistance. And so trying to use, if you have to use a beta blocker, a vasodilating such as carvedilol or nebivolol will be helpful in patients who are struggling with their weight. In the UK-PDS, in patients with diabetes and hypertension, atenolol caused more weight gain than captopril, with a non-significant weight gain over 9 years. Those with the atenolol group required additional anti-glycemic agents, and they had a worse A1C. Harkening back to the 2017 ACC-AHA, I'm happy to see that beta blockers feature nowhere in first-line agents for blood pressure management. And then this is just a quick recap that there are a lot of medications here at the VA. The majority of our veterans, sadly, are on multiple agents that cause weight gain. The most common ones are in red here, versus alternatives to consider that promote weight loss would be something to consider for all of us prescribing medications. I'm happy to provide this. I'll provide this to the team here, a handout that we worked on with our last guidelines that I'm hoping to update for agents that cause weight gain versus agents that are more weight neutral to weight loss, to put up next to every computer that you guys have where people prescribe medications. I suggest looking for insulin resistance. Acanthosis, this one is not subtle. It can be much more subtle in terms of the back of the neck, the axillae, or the intratriginous fold. If you see that hyperkeratinization of the outer layer of skin, that is the first demonstration of insulin resistance, and likely they're on a path towards cardiovascular disease. And so you'd want to consider either a hemoglobin A1C, or earlier than that is going to be a postprandial glucose. So I no longer get fasting labs. The European Society of Cardiology agrees, and a lot of the societies agree, that you don't need and don't want a fasting lipid panel, because you will be putting your head in the sand in that triglycerides that rise after glucose, basically a glucose stress test for the lipids, tells you something that you want to know. This person needs more help and needs to be more aggressive with lipid lowering. So I wouldn't get fasting labs anymore, except for very rare things that are endocrine specific. Increased waist circumference is useful for considering additional risks to visceral adiposity, which has a specific increased risk for cardiovascular disease. And then let's get back to Mr. H. So Mr. H, what did I do? What are we going to do in this patient who's 80 years old? He's frail. He definitely has high risk for sarcopenia and lean muscle mass. You lose about 1 pound of muscle mass for every 3 pounds of weight loss, and that's regardless of the way that you're losing weight. I think there are some agents in the pipeline that we're all incredibly excited about, activin receptor inhibitors. However, they're not currently on the market. But in the end, given his body mass index, his goal for surgery, his uncontrolled type 2 diabetes that was complicated with renal disease, as well as known having had a stroke, which GLP-1 agonists seem to be a little bit more helpful for reducing the risk of stroke. I thought he was a higher risk for falls from an SGLT2 inhibitor therapy, and they are less helpful for stroke management. So I did prescribe for this patient the semaglutide Ozempic, and we will be dose titrating as he tolerates. So these were my questions. I'm going to take a little pause here to see whether the team wants me to go through the questions, or was this something, I think I misunderstood whether you got the questions already, or
we can people will get them when they claim their MOC, but you could go through them if you want.
Oh, okay. Well, we can do a little bit of audience response here. So hopefully this was my main goal for this audience. What is the agent to treat hypertension that will cause the most weight gain over time and should be avoided when feasible and safe to do so? I clearly understand that in the settings of arrhythmias and atrial fibrillation for rate control, this may be required. And let me see if I can do the, where's the chat? Chat bar, here we go. Do we have, oh, good, we've got a B. Okay, so we have a winner. Aditi Patel, you are our winner today. Metoprolol was the answer. So try to, any of the other agents, and I would certainly add, ideally, I'm hopeful that SGLT2 inhibitors will get added eventually to the agent options for blood pressure control because of the secondary benefits along with it. But that's not yet in any guideline that I've seen. So question 2, which of the following does not have a specific FDA indication yet, as of this writing, for the NUSHs? So is it tirzepatide that has an indication for diabetes, weight loss, and obstructive sleep apnea, moderate to severe? Is it semaglutide for diabetes type 2, weight loss, and CKD? Is it liraglutide for type 2 diabetes and weight loss, dulaglutide for type 2 diabetes and weight loss, or is it semaglutide and tirzepatide for heart failure with preserved EF? Any takers? And this is the negative. So which one does not have an FDA indication? Yes, so agreed. So sadly for those of us on this call who have an interest in heart failure with preserved EF, these are not yet FDA approved. But the data so far is very encouraging, and we're all hopeful that this will make its way through the process. And then question 3 is maybe a little bit nitpicky, so I might just go through it. This was to just highlight that not all of the GLP-1 receptor agonists have shown actual benefit on the 3-point MACE on their cardiovascular outcome trials. So these first 5, liraglutide in the LEADER trial, semaglutide as the subcutaneous injection, Albiglutide Harmony Outcomes, that one got withdrawal because they just couldn't, there wasn't enough commercial benefit for that manufacturer, which is always sad to me, because the more we have on the space, perhaps the better the cost for our veterans, for our patients. Dulaglutide Rewind and epaglinitide, which is not on the market. It's more research-wise because it's an extendin 4 versus the human GLP-1 agonist. It was to see whether that had something to do with why these ones, the Elixa and the exenatide, the Excel, were not positive, but this one was positive. So all of the first 5 did show absolute benefit that was statistically and considered clinically significant on their cardiovascular outcome trials. Versus the oral agent, the Rybelsus Pioneer 6 semaglutide, did not meet its MACE outcome, nor did lixoxenatide or exenatide. So just something to keep in mind when you're perhaps filling out those insurance pharmacy benefit questions. And then treatment pearls. Am I making this harder? Am I contributing to this person's weight and struggle with their weight? So I would suggest everyone who prescribes a medicine should be reviewing medication lists, maybe sending messages. You've been educated, you've got the knowledge to folks who may have not gotten this talk, whether their medications are making it harder for them. Maybe enlist the help of a pharmacist. This is where our pharmacy colleagues can be very helpful. I would always ask for permission to talk about weight. Weight is a sensitive topic for a lot of patients, and see where they are in their desire for change. We've talked, I think I've definitely driven home my dislike of beta blockade from a weight perspective, and then starting with low-hanging fruit, no liquid sugar. The key takeaways for today is that NUSHs, nutrient-stimulated hormonal therapies, which all of them currently contain GLP-1 receptor agonists, but with extra add-ons, and the add-ons definitely seem to be beneficial because from the GLP-1 agonist monotherapy to the dual agent to the triple therapy, we're seeing further improvements in weight loss. And as we've seen in that table before, the more weight loss you achieve, typically the higher improvements you have in obesity-related conditions. So don't prescribe medicines that cause weight gain. Please switch. If you have to have a beta blocker, could it be a vasodilating one? There's lots of exciting agents in the pipeline, but there's still a lot of unanswered questions, specifically about the risk for sarcopenia and muscle mass loss, or is it that we're not looking at the right thing? What about weight regain after cessation? What about cost? So with that, I will thank you all so much for your attention and happy to take any questions.
Good morning. Sorry.
Thank you. Go ahead. No, thank you for that wonderful talk. Yes, we can hear you, David.
Yeah. This is Dr. Choker. Hey, thank you for a great talk on these new agents that are multifaceted for different systems. But I wanted to ask you, I've had patients who come in to see me. They are very happy with the weight loss after using these medications, but they keep on complaining about feeling dizzy, and sometimes they say that their blood pressure is dropping. What is your experience with that?
Absolutely, yeah. We've had to cut patients antihypertensives. That is the medication class that we have to cut the most aggressively, typically, along with if they're on insulin therapy because of lower requirements. So we've taken people off of most of their antihypertensives and just kept them on basically the ones for renal protection. So a low dose of an ARB with an SGLT2 inhibitor if they can tolerate it. These medications are amazing. Maybe eventually they'll be added on ACC/HA for treatment of hypertension for those where the hypertension is driven largely by obesity. And it's similar actually for the obstructive sleep apnea, where it's the obstructive sleep apnea that's caused by obesity is improved. Obstructive sleep apnea that is caused from something else does not get improved. Similarly, for folks where the underlying cause of their hypertension is not through obesity-driven mechanisms, meaning perhaps it's hyperaldosteronism, perhaps it is, going to be rarely a pheo or some other cause, and that will not typically get improved with the use of these agents. But the answer is to stop their medications, stop their blood pressure medications. What you probably cannot stop is the GLP-1 medication for their weight loss, because the weight will come back. I hope that answers your question.
Yes, it did. And yeah, thank you so much.
Dr. Mayer, I also have a question. Would you mind, speaking to the recommendations that you give your patients for specific exercise plans? Especially, you mentioned, the concern for sarcopenia and muscle mass loss. So how do you navigate that conversation?
Absolutely. What a good question. And let me see, actually, I'm going to, hang on. Let me, if I have just a couple minutes, I will pull up, there's that paper that we talked about that was the, the paper on, these two papers are actually excellent in terms of how to try to mitigate what we know is going to happen. And there's a concern that the more rapid the weight loss, the larger the percentage of the lean mass that will be lost in comparison to the fat mass. And so that is an issue where a lot of us in obesity medicine are concerned. Perhaps we need to slow the titration and not go up quite as rapidly on the agents. But sometimes our hands are tied by the insurance companies where they won't let us, like they're saying that we have to use full dosing or they won't pay for it. Usually what we recommend is a combination of both a higher protein diet, which you have to do that carefully though in the setting of especially renal disease. So I tend to try to encourage folks to work with a dietitian. And if they have renal disease, one who has experience with that, navigating that, in terms of goals for aiming for somewhere between 0.8 grams of protein per kilogram up to 1.2 or perhaps more, depending on the person. And then for the exercise physiology, what a great question. I definitely think that we do not have all of the answers here. So we absolutely refer folks. We tend to do it after they've achieved a little bit of weight loss, meaning that initially mobility is sometimes so limited in our veterans that it's not the right timing. And you also sometimes get more bang for your buck in terms of weight loss, which causes a positive cycle where they see some weight loss, they're encouraged, they make more changes. So we tend to wait just a little bit in terms of achieving a little bit of weight loss, and then we try to refer them as soon as possible to kinesiotherapy. And so if you have access, if the veteran has access through their insurance to an exercise physiologist, that would be, of course, ideal. We don't have all of the outcome measures that we would like in terms of knowing that we are achieving improved muscle quality. That's part of the limitation. And so we're using kind of surrogate markers like the 6-minute walk test and like, the hand strength and other things that are followed that may not give us it certainly wouldn't be what you would get from like a muscle biopsy in terms of quality. But the bottom line is that we encourage, and we do, however, in MOVE, we don't say specific, we hesitate to give specific direction other than to simply continuously encourage more movement. Meaning more movement, and it depends on the patient a little bit. So some patients thrive on very specific recommendations, and in those cases, we do try to follow what's recommended by our kinesiotherapy and electrophysiology colleagues in terms of frequency and intensity. But for a lot of veterans, that kind of puts them off from the goal. And so we simply talk more about, what do you find fun? What do you enjoy doing that is physical activity? Give me some examples of things that bring you joy and pleasure that are physically active, and how can we work those more into your day? For folks who feel like time is really an issue, we talk about much smaller goals, such as go up the first flight of stairs before you take the elevator. Park a little further. That's not a problem at the VA. You can't find parking, so we certainly help on that count. But I think these are great questions that we don't have all the answers for.
Wonderful. Thank you so much for answering that question so thoroughly. That's very helpful.
Dr. Mayer, I have a question as well. My name is Arun. I'm one of the Cardiology fellows.
And I'm sorry, I cannot hear very well. It's not coming through for me. You may have to speak up. I apologize. I think my speakers are on 100%. Let me triple check on that. But I'm going to need you to either speak up a little bit or maybe type.
Can you hear me right now?
Oh, yes, much better. Hello. Hi, Arun.
Hi. So my question is, has the use of Nucius been studied in patients that have baseline elevated cortisol levels? And the reason I ask this question is you've worked with the population, which is the VA essentially, and they have definitely undergone some, very traumatic experiences. So I was thinking that, this subset of population might have baseline elevated cortisol levels, which may be contributing to their weight gain and inability to lose weight. And the second question is, in patients that do have elevated baseline cortisol levels, I'm guessing that the way cortisol works is they would also lose lean muscle mass much more than the normal individual. So how would GLP-1 or Nucius be, or Nucius would affect their lean muscle mass level?
Absolutely. That's such an interesting question. So a couple things to kind of start the discussion here. In endocrinology, we do not recommend checking random cortisol levels. There is no validated use to random cortisol levels. So that is not something that we would recommend at all in clinical practice. That might be a little bit different in research. Now, I agree that there's been a lot of kind of increased interest in folks who have what's considered either cyclical Cushing's or what's being called kind of subclinical Cushing's. And that's a really interesting population where there is a concern that they have small adenomas that may be producing without the appropriate feedback, kind of autonomously producing excess cortisol. And so these are actually considered folks who are perhaps on their way to Cushing's disease or in that case, if it's adrenal, Cushing's syndrome. And that would need to be evaluated and picked up differently. So this would be, so the simply having obesity and this idea of like either adrenal fatigue or excess circulating cortisol has not been validated or considered a true diagnosis from the endocrine community. So I'm not sure that I would use that clinically in any way. I would perhaps simply focus on more of our metabolic markers. So I would much more focus on markers of insulin resistance. So specifically the lipid panel, I think, is one of our best markers, as well as the hemoglobin A1C and a postprandial glucose and postprandial triglyceride are going to be very useful markers for our patients in terms of monitoring improvement. I wouldn't use cortisol as a marker for either insulin resistance. Now, if you are worried that the person has underlying Cushing's syndrome or Cushing's disease, so autonomously produced hypercortisolemia from various sources, whether it's an adrenal source or you're getting an ACTH production from either the pituitary or another site other than the pituitary, although those folks typically, right away, and they present very dramatically. So these would be more for this group of patients that's being, I think we're early in the discussion of autonomously producing cortisol, you would want to refer those folks to endocrinology for an evaluation. So either you're doing dexamethasone suppression testing to see that their cortisol suppresses less than 1.8. That is the currently recommended methodology. A 24-hour urine cortisol, where you're looking for the cortisol to be less than 50. You're going to want a creatinine with that, or 2 late-night salivary cortisols for patients who do not work night shifts and don't smoke would be options as well. But so I think I'm not sure that I agree with the premise, and I would look at other markers. I hope that answers the question, or if you feel like it doesn't, let me know. Give me some more of your thoughts.
Sure. Yeah, I think my thought process was I was just trying to link like the veterans' experiences, and I was kind of hypothesizing, if based on their past experiences, they might have elevated cortisol levels, and that could actually be contributing to their weight gain or inability to lose weight. So I was just wondering if we start including niches in terms of treatment, how do they respond to it based on
No,
that hypothesis?
we have looked at PTSD and ACE, so adverse clinical childhood events, adverse childhood events, in terms of increasing the risk for obesity. And in those cases, so I agree with you that mental health absolutely, unfortunately, there's a bidirectional positive where depression causes obesity and obesity worsens depression. And so there's definitely a strong overlap and a strong incidence of mental health concerns in our folks who live and struggle with obesity. So in that case, especially from folks who have seen traumatic events, or had traumatic brain injuries, I completely agree that it would have a negative impact likely on their health. And I think that I would use outcome markers of like the mental health monitoring validated tools in terms of measures of PTSD, measure the GAD-7, different markers for mental health and effect, and whether those are improved. There's a lot of interest in the GLP-1 agonist and NUSHs for effects on areas of like alcohol use disorder and drug use disorder, and whether by reducing cravings and reducing levels of the appetite center, that can be useful. There have been other people who've been talking about looking at it for obsessive compulsive disorder as well. And so there's probably an overlap there that is absolutely true. So I would agree, and I would certainly endorse more research, but I'm not sure that I would use cortisol as my outcome measure.
Excellent. Thank you so much, Dr. Mayer. We really appreciate your time today. And thank you so much for this wonderful lecture.
My pleasure. You guys know how to find me. You have my VA email, and I look forward to seeing you guys soon and collaborating on patients.
Thank you again.